This video is from a webinar that was hosted by the Mental Health Association in Michigan on February 16, 2021. The Mental Health Association in Michigan hosted a panel discussion about the topic of suicide with 3 experts in the field of suicidality. The goal is to provide information to the community about suicide. This video contains sensitive material that might be upsetting for some viewers. Viewer discretion is advised.
Thanks for joining us today. My name is Marianne Huff, and I am the President and CEO of the Mental Health Association in Michigan. So I welcome you today and appreciate your participation. Today we're going to be talking about the subject of suicide. And just a quick note about this, of course, talking about suicide can be intense for some individuals. The goal of this webinar is to talk about suicide from different perspectives, which is why it's called Perspectives on Suicide. And what we're really looking at is not just talking about traditionally what a lot of folks talk about during these webinars, what to look for and those types of things, but we're looking at emphasis upon social and environmental factors that contribute to a misunderstanding about suicide. Also, unfortunately, the pandemic has really highlighted the fact that a lot of people have been struggling with mental health conditions and are not able to get treatment, and there has been an increase in suicide. So today, MHAM is hosting this panel discussion about the topic, and we are really fortunate to have what I consider to be 3 experts in the field of suicidality. The goal is to provide some information to you about suicide, but then we also want this to be an interactive process with all of you that are attending today. So the process this evening is I'm going to introduce the 3 different panelists, and then each panelist who has a different perspective on the topic of suicide will talk about themselves and their perspective, what brought them into an interest in this topic. And then after each panelist has about 7 to 10 minutes to talk, then we're going to have a roundtable discussion where I will be asking them a variety of questions. At any time you have a question, please raise your hand or put your question in the chat box, and Kristen Taylor, who is our wonderful moderator, she will keep me apprised of the questions, and we will go from there. So please, feel free to ask your questions and share anything that you feel necessary that you would like to share. So I'm going to go ahead and get started. The first person I'd like to introduce is Kate Hardy. Kate is the founder and the executive director of an organization called 6 Feet Over. The mission is to provide financial and emotional support for survivors of suicide loss and individuals with lived experience of suicide, while engaging in community prevention through mental health education and advocacy to support healthier futures for all. 6 Feet Over and its novel outreach program, Suck It Suicide, are focused on post-intervention support as well as community mental health, with a special interest in the non-mainstream community and youth demographics. Kate is the survivor of 9 losses by suicide, beginning with the loss of her mother in 2003. She was recognized as the 2017 American Association of Suicidology Loss Survivor of the Year, a member of the National Suicide Prevention Lifeline, Individual and Family Lived Experience Committee, the Lifeline Chat Work Group, an advisor on the Michigan Suicide Prevention Plan Work Group, a member of the International Messaging Advisory Group, and an advisory committee member of Texas Suicide Prevention Collaborative, and a national speaker. So we welcome Kate. Then we have Amelia Lehto. Amelia specializes in crisis intervention and suicidology on the local, state, and national levels. She's on the board of directors of 6 Feet Over, an advisory board member of Kevin's Song, and has her own lived experience with suicide. And then we have Andy Wright. He's an essayist and an activist. He has presented at several MLA conferences and written on topics ranging from suicide and mental health to gender studies and politics. Welcome, Andy. So I'm going to get started here. We're going to start with Kate. Kate, would you like to tell us why you're here this evening?
One, I was invited, so thank you for that. Appreciate it. But I'm here because of my life as a whole brought me to it. It was a weird path. I grew up with a mom who had bipolar and did die by suicide in 2003. And then following my mom's death, I've lost 8 additional friends to suicide. So even though losing my mom was a very monumental moment for me that taught me a lot of lessons about being an immediate family member who is now a loss survivor. But it was the losses of my friends that actually showed me what more of the need was within my own community, which is made up mostly by artists and musicians, people in a non-mainstream community, and those who wouldn't generally seek out the help of what is mainstream suicide loss support or mental health support for that matter. So my whole focus through what is now my career is making sure that all the niches that could be out there are recognized, and knowing that not all people are gonna latch on to the pastel kitten hanging from a branch, just hang in there, do some yoga kind of mental health care and the messaging. So we've changed up the messaging. We try to make it a little bit less clinical, have normal conversations with people where they are and not expect them to come to us. So a lot of festivals and concerts, places that you wouldn't generally see a mental health advocate, let alone an entire nonprofit showing up. And we sell merch, which is something I really enjoy doing. But that's generally what brought me here, and the support of people within the mental health field that said, yeah, this is rad. This is something that is probably needed, and welcome, we'll teach you things. So Amelia was actually one of the first people to reach out within that field and say, hey, what you're doing, it could be a thing. So yeah, and now it's what I do all the time.
Thank you, Kate, for sharing that. We really appreciate you being with us this evening. Thank you. Amelia, what brings you here today?
Thank you, Katie, and you're welcome for your life's path that I was able to help bring to fruition through my love and support and guidance, like Yoda. That's all. So I actually came into this work over a decade ago, and it was after 2 major losses in my life. So 10 years prior to that, I had lost my best friend to suicide, and it changed the trajectory of my life. It was while I was in middle school. It was a very influential time in my life, and I went through my own struggles of suicidal ideation, of clinical depression, and teenage motherhood. Following the birth of my son, I lost my mother to pancreatic cancer, and I was at a turning point in my life again. And I was an adult, and I had to make my own choices, and finding somewhere to volunteer was my saving grace at that time. And it led me to this career in suicidology. It's a thing, look it up. It's connected me in so many different ways to those in the community that are in their own struggles, their own pain, but ultimately their own perseverance and resilience that comes with going through stuff in life. And that was what called to me when I saw the Suck at Suicide page scroll on my feed on Facebook 8 years ago now. And I knew that she had something special, and it spoke to what I would have been attracted to when I was younger, and obviously still am. But I knew that it wasn't the traditional mainstream messaging. And this organization in particular has turned into something that's incredible, and one of the only, if only, organizations that provides financial services to families after a suicide loss. And it's entirely grassroots right now. It is by the support of the community, by the support of those that believe in this mission, that believe in the organization, that bring financial services to those most in need after an unimaginable loss. Among many other services, we work with survivors of suicide loss, helping connect them to mental health support in their area, getting them connected sooner, which ultimately, postvention is the work that we do, is prevention. And a lot of my experience is based in that. And that is some of the work of the suicidologist co-founder of Dr. Edwin Schneidman. And we see it in action through this organization, which is pretty incredible that we are able to give back to those that are most in need in the state of Michigan, and soon to be beyond is the plan for us here. These tangible services are what connect us. The conversations that we have, the messages that we exchange, the services that we provide are ways that really connect people to the care and support that they need in some of the worst times of their lives. So I'm really excited that Mental Health Association of Michigan is having this conversation, and I look forward to the next hour with everyone tonight.
Thank you, Amelia, for sharing that. Andy.
So yeah, I guess what brings me here today. So I've personally had struggles with suicide ideation throughout my entire life. I've grown up, I had several losses through suicide. I've battled depression, anxiety, OCD throughout my entire life. And so one of my main focuses of study that I've been writing about and working on for the last few years has been ideology specifically, and even more specifically, suicide ideology. So what that essentially means is everything, like kind of how the lens through which we view suicide and mental health today. And right now there's two main currents of that ideology that we face. On the one hand, we have this ever-growing market of consumables where mental health today is this thing that we can work on if we buy the right products, the right services, take the time to breathe right, eat better, drink more water, take more personal time to relax and meditate. In this market for mental health, we have this new affordable alternative to Western medicine that is essentially predicated on having a positive mental attitude, having enough self-care, and buying the right teas and vitamins and supplements and incense and light masks and acupuncture kits and DNA mapping, doing yoga, taking mindfulness classes. And the hook here is not that this market actually offers a way out for those who can't afford actual treatment, but that mental health does in fact coincide with this foundation. And unfortunately, these are all things that are facts of any form of health. However, if we accept this, then we also have to accept that those who live in areas with heavy air pollution, or those who have access to healthy foods simply because there's a Whole Foods nearby but can't afford to shop there, or those who work multiple jobs or depend on public transit, or single parents and don't necessarily have a whole lot of me time, those who have unreliable water supplies, these people both have no chance at mental health, but also don't deserve health simply because they haven't done enough to change their surroundings. And that's the logic we accept here by taking that view. So in short, mental health is something that people with money and time can focus on for the sake of their diet or their health regimen, and it becomes a novel luxury. So mental health as a market is predicated on cheap or free labor, whether our own insofar as we can afford it, or others, meaning we have the time to focus on ourselves because of the lower, quote unquote, unskilled work of others. And the other current today is this desire to fully objectivize suicide. And by that, I mean to say there exists this view that if we focus on the statistics enough, not only can we prevent suicide, but we can predict it. And the problem here is that this treats suicide as this thing outside of our world, as this intrusive event which not only is unexpected, but doesn't belong. And the unfortunate truth of our history is that suicide does in fact belong, and it's very much our history. And we have this trouble with this history that we just can't accept. And so the paradox of suicide is that it's unpredictable and yet expected. And so the fact that today we want to work so much at predicting it for the sake of feeling that it's still unexpected is very problematic. This view betrays the fact that it's very much of an older ideology of suicide that's inherently racist and classist and sexist, that suicide was part of a lifestyle of the poor or the working class or women and BIPOC. So the more we treat and view suicide as this thing outside of our world, as somehow disconnected from us, the more we will retreat into this view that suicide is solely an individual problem, and the more we will continue this crime of history. So that's pretty much why I'm here today.
Okay.
In short, that's fine.
In short.
Well, thank you. Thanks, Andy. Thank you, all three of you, for sharing that and explaining to us why you're here. And again, thanks for being here. So now comes the best part, where we get to talk about these questions. And so I think, given what all three of you have shared, maybe the question to start with is, what is the best approach to addressing or talking openly about suicide and mental health? So I address it to all three of you, and whoever wants to respond, please do.
I don't necessarily think that there's a best way. I think that there's every single person is going to respond differently to a different way that you talk about it. I do feel very strongly, though, that our own communities and our own peers and our own family members are more likely to be an influence that is more helpful than shoving somebody towards a crisis line or shoving them into a hospital. People don't feel like they have control, and oftentimes what we want to do to somebody who doesn't have any control already is to take more control away from them. But we do a real crap job of teaching our community on how to talk to the people around us that we're concerned about, or how to recognize somebody who will listen to you, who are the people who will be there for you. And that, to me, is it's wrong. I mean, I relate this oftentimes when I talk to people to breast cancer. I mean, 30, 40 years ago, you didn't talk about breast cancer. If somebody in your family got breast cancer, it was yuck. You don't want to talk about it. It was gross. And now we have football players wearing pink. We have people wearing shirts saying, save second base if you won't feel them, I will. There was a culture shift in acknowledging and recognizing who would be at risk, how to find the signs, what you could do to support the person. There's, casserole meal signups, and to take somebody to the doctor or be there for the person. But we don't tell our communities that you can do the same thing for people who are having a mental health crisis, somebody who's suicidal, somebody who's just having a bad time in their depression right now. What can you do for them? We do a real crap job of that. We just tell them, this is a problem and you need to go talk to this crisis line, or this is a problem and they could hurt themselves, so let's hospitalize. That's where I'm at on that.
Yeah, it's very much this thing that's always already considered a very private matter that's meant to be dealt with behind closed doors. So in that approach, I think it kind of begins with the impolite. There's really no polite way to truly talk about suicide or mental illness. Because asking for help is something victims are supposed to do, and our tolerance for victims in this society is very minimal when they're all too close to us. So unfortunately for us, we have to kind of break some of the social norms of conversation and say things that will upset those around us. I mean, it's called suck at suicide, But first and foremost, I think you need someone around you that will respect what you have to say, at the very least in retrospect. And sometimes the best approach to talking about this stuff is realizing the limits of your social circle. You have to know who's willing to relate first. And it's all very contingent on that, of I guess, your social circle and who you're looking to reach out to. And I know for a fact that it can be just as helpful and satisfying, if not easier, to not necessarily reach out to your social circle, but to reach out to certain organizations. And these organizations don't necessarily need to have anything to do with suicide awareness at their core. But so many organizations are also looking to tackle that as well. So I know in my own experience that I've been able to get involved with certain organizations and take on that aspect of something that maybe they didn't have the resources to deal with to begin with.
It's also having these conversations. I think in light of the pandemic, we're having to reckon with some real social disparities, and in a way that we never had to truly look at it because we are all so isolated for the most part. And hosting these events that are free, maybe you have to register, provides a level of accessibility to those that maybe were inaccessible before, or you were unfamiliar with where to find these types of events to attend. Shared likeness. I mean, we thrive on community as social beings, and through over the years, through technology, as advanced as we've become, we've also become disconnected in a lot of ways. And finding your people is so important. And we know that our people are often our very close circles, as Andy and Katie were saying. But it's also the larger conversation that we're starting to hear more of. I've been in this work for a decade, and every year I hear more and more about mental health, about mental wellness, however people want to package it, but also about suicide, which is very hush hush. Still, a lot of the times, it's not only the social factors that not only stigmatize, but provide bias or prejudice or discrimination, but it's also the internal conversations that we have with ourselves, that internal dialogue of something's wrong with me, nobody's going to understand me, nobody's going to listen to me, nobody's going to take me seriously, nobody's going to understand. And I say that because I have felt that way myself. I provide crisis intervention on a national level, but nobody can talk to me the way that I can talk to myself. So there's like that fight of, I can get through this, but F this place. This is really hard right now. I don't want to do this. And nobody's going to talk to me the way that I talk to other people. So it's reckoning with yourself of, who can I talk to? Where am I most comfortable having this conversation? And just starting to share with somebody that you trust, whether it's a Katie Hardy in your life, or an Andy Wright, or a Marianne Huff. Find one person and start having the conversation. And sometimes it's setting those expectations of, I need to vent right now, or I need your advice, or I need you to take me to my doctors or my father's, or wherever that safe place may be, or just hold my hand. Sometimes just holding your hand and listening can be the greatest thing that we can give somebody, and showing up.
When we do outreach in the general public, this is not an uncommon question, like, what can I do? And usually my first response is, shut up, just stop talking. Like, it's not about you. And I know it's going to feel really, really uncomfortable, but you need to listen to that person, and anything that they say, you need to respect. They have those feelings, they have those thoughts. And if you, retort, and if you go, well, you have this, or no, you don't feel that way, you need to actually listen to the person, and then possibly give them some form of agency. Go with, give them options as to what might be possible for them. What would they be willing to do? It's crisis work 101, but we don't teach that to people. That's a thing that we keep within the suicide prevention, crisis work, counseling, professional field. Why can't that be something that's taught in high schools to kids? Like, they have to learn CPR. It's a lot of times very simple stuff, but people don't know it because we don't teach them. But on both sides, it's a comfort level. Like, I wouldn't talk to Amelia while she's in crisis the same way I would talk to my brother. It's knowing your audience. So it's not one size fits all. And we would love to make it that way. But as Andy was talking about, like, and Amelia, I just like to mesh things together, but it's not black and white. It's all a gray area. And we need to, kind of get that message out that you just have to feel out the room. If you are the person who needs somebody, figure out who would be that best fit. If you are somebody who's worried about somebody else, okay, well, talk to them like you normally would. You don't have to freak out. Like I would honestly call my brother and I'd be like, what the hell's wrong with you, you moron? But I wouldn't do that with Amelia. My brother would respond well to that. Probably, maybe, I don't know. But depending on his day. Amelia, it would be like, I'm worried about you. I know you've had a lot of stuff going on. Tell me things. It's just know the room, read the room, and then shut up.
I think relatedly, I saw Jan's question in the comments, and she shared that she's a social worker who works with families directly after a loss, and that's part of that conversation of being present. I will call you. Thank you. I'm okay right now. Is being present for the family in the most critical moments following a sudden tragic loss of suicide, is being present with the family and being present with the individuals that are affected and meeting them where they're at. If they want to share how they learned of the loss and what brought them to this space with you, start there. If it's just a connection to services in your area, letting them know that there are survivors of suicide loss resources, whether it's 6 Feet Over or Kevin's Song locally. If you are in the Thumb area, there's the Barb Smith Resource Center. There is a variety of services in the state of Michigan to connect people to, and letting them know that these resources are available and accessible to them, because we don't have Coca-Cola money, so we don't advertise, and people are not familiar. It's often word of mouth.
As a loss survivor of many, and I know Andy and Amelia are also both loss survivors, but using their person's name is super important. It's always been really important to me. Don't be scared to use their person's name. It gives them the freedom to also do that. It immediately after a loss shows them that it's okay to still talk about their person. There's nothing to be ashamed about. You definitely can use your person's name. If they're feeling really uncomfortable, they're not really sure where to start with all of the administrative procedural stuff, ask them to tell you about the person. Tell me a story. What were they like? What was their favorite thing? Just get them to talk about their person, so that way they know that their person isn't forgotten and you're there for them, but you're not just there because they lost somebody. You're there because they lost somebody who was really important to them and who impacted them and made them the person that they are. So that is a huge thing for me. Anytime, actually, I think this right now is somebody who watched me grow up and knew my mom. And I don't know very many people who knew my mom. And she's on here. And I love hearing stories about my mom. I love it. My mom was a dick a lot of the time, but she was also an incredible woman who had her own life. I love hearing about that. So that's one of the biggest things, is talk about that person and use their name.
Thank you. Just want to add that part of what needs to happen is looking at mental health through the lens of like any other medical condition. And I really appreciated you talking about holding somebody's hand and how important that is. We would do that with someone who was in the hospital dying of cancer. We would hold their hand. But we don't think about doing that when somebody's in the middle of a mental health crisis. I think we really need to reframe the way that we look at it. I mean, the undercurrent here obviously is about stigma.
Mm-hmm.
So thank you.
Thank you. Yeah, and if the person does go to the hospital, if that's what they choose to do, be there for them. I've held many hands in the hospital and brought many gift packages or items to pass the time if they're being assessed. So thank you, Marianne.
Oh, thank you. So next question for all of you. What are your experiences with mental health services, whether they be public or private?
So I have the benefit of being a middle-class white woman from the suburbs and from a fairly affluent family. And when I needed help the most, my family had access. And I was able to get into therapy with a professional that my older sister had seen and had helped her greatly and had met me where I was at the time. and I was very young, and I was able to get into a treatment facility that I don't think is around anymore, but it was so impactful that when I saw one of the staff members years later, I thanked her for being there for me in the moment that I needed it most. And working now in this field, I see the disparities. There is those that have great access to well-informed services and those that are struggling to just get a call back from a mental health professional, and those that get connected to the community mental health service and they get great care. Sometimes they get greater care than the private practice because of the pipeline that offers them access to these clinicians and these professionals and the peer support movement that is growing more and more to just relate to somebody on a level that clinicians can't or won't connect to people. So there is this great divide of public, private, and location, really, where people live. If there is services in their area and there are connections that can be made among many other factors. I'd love to hear from Andy or Katie about this as well.
Yeah, so growing up, it was definitely not something that I could afford, working the one job that I had for so long, and it was not something that was covered in my health insurance. So it was well into my probably late 20s, I guess, at that point, where I actually started seeing a therapist, and took years to find the right therapist. And in fact, like many, I spent years with a therapist that didn't really do anything for me. I guess laying that foundation of being comfortable about, talking about anything that's important, that's a good start. But if it's not moving beyond that, you got to recognize that and quickly move on. It sucks and it's a terrible process of trying to find the right therapist, but it's literally all we have right now. And at times I was lucky enough to have this covered by insurance, and however many times I had to pay straight out of pocket. I'm still fighting with a clinic over some bills from 2 or 3 years ago. And so anyone who's ever had to transition from employer-based coverage to COBRA knows the headaches of dealing with bill collectors, and anyone who has taken that chance and put in the months or years of that labor without any coverage at all knows how bad it can. At this point, I've had something like 12 or 13 different therapists, social workers, psychiatrists, behaviorists, etc. Been on 8 different medications, all within the last 10 years or so. I spent an evening in psychiatric emergency services. More recently, I've used the Talkspace app, but it all adds up so quickly, whether you have coverage or not. And a big part of the problem currently, especially with trying to find that service that works for you, is you that good that you feel, you don't know until you actually feel and see what it looks like and you can witness it. And I put in several years of therapy before I even began to know what that meant. And so it's hard to constantly put in the effort and thinking of something will change. So you start the question of why even go? And so the other piece, if you do show up, why push through that resistance that we all feel when we have to talk about embarrassing stuff? It's hard work that never gets much easier. It only gets more familiar. And through that familiarity, things lose their power over you. So, those get easier to talk about. But having to constantly re-explore and go back to the starting point, that's hard. That's very hard. And the thing is, when they feel hard to talk about, you're doing it anyway, that is the beginning of it. And probably the most optimistic we can truly be about anything with it. So when you feel that resistance, that means you've found your starting point. And the thing that feels like despair at first, but you must learn to kind of accept as part of it, or any sort of meaningful work whatsoever, is having to begin again, because it will happen. And it doesn't mean it didn't work the first time. It just means something was missed. And given the infrastructure of just how mental health care is in this country, it's very difficult to have to go through that and go through the system and go through the process of trying to find the right person again and again.
Thank you, Andy. I agree with you. Kate?
I have very minimal experience with myself. My parents took me in high school, but my mom told me to lie before I went in. So I lied my way through it, and they told my parents I was extremely well adjusted, which was a lie. And then my experience after that was about 6 years ago. I went to go see a therapist to work through some parental issues that I have with my parents. And the therapist ended up not being so great, asked me more questions about suicide prevention and my current job, which was working in special education, than she did actually focusing on anything that I needed to be there for. One of the best, but also kind of troubling downsides to what I do now is that I know a lot of therapists, and I feel like they're the great ones, and they're super passionate about what they do, and they really care about their clients, and all they really want to do is make sure that their people that talk to them leave feeling better or have more insight than when they came in. And I can't go to any of them. So I'm also really lucky because I can kind of shoot something by them occasionally. And they're also the really good listener friends that I have. They're not going to treat me as they would a client. They're going to treat me like I'm a friend, but they're also some of the best listeners out there. I'm still on the lookout. I'm still trying, but I haven't had a ton of luck. My mom, she had a very successful run with a therapist for about 20 years, I think she went. The medication that she chose to take, and it wasn't ever pushed on her from what I understand, worked really, really well. But then amongst a 1,000 other things that happened in 2003, she also changed therapists who also changed her medication. So I don't really know because she's gone, so I can't ask her too many questions about that. But yeah, that's my experience. I have many therapist friends. I have many PhD friends. I have many social worker friends, and I love them all because they're beautiful humans, but that much harder for me to find a good one myself.
Well, thank you. Yeah, it makes it difficult if you're friends with all the good ones, then it makes it challenging, doesn't it? Just want to say something too, as someone who is a therapist, a small private practice. What I tell the people I work with is there's no silver bullet for any of this stuff. And that basically, you can start with one therapist and then get into some issues, and then maybe you move beyond that therapist to go on to somebody else. The other thing I will say is I think therapists should be in treatment themselves so that they are always continually working on their own stuff, because what we know about being a therapist is a therapist can only take the client as far as they have gone themselves. So appreciate your feedback around that issue. The other point I'd like to make before the next question too is there is a difference between public and private mental health services. And sometimes folks will find that they have a higher quality of care in the private sector, depending upon their insurance and where they can go and their level of income. And then sometimes they'll go to community mental health and they'll get better, sometimes worse care. I think it's kind of the luck of the draw sometimes, but those are really, really valuable points. So kind of, taking it a step further, we've talked about how do you talk about this? What are your experiences? I think the next question is, how do you, what types of socioeconomic barriers are in place that inform and perpetuate our view of mental health? I'll address that to whoever wants to take it first.
I'm sure Andy has a ton to say on this.
Yeah, I got a lot of stuff to say here.
Take it away, Andy.
Well, I mean, first and foremost, if healthcare really must cost this much, then we have to start addressing all the other micro arguments that go with that. Then we have to accept that minimum wage, in fact, does need to go up, that the service industry does need to be properly compensated for. We need to address material economic disparities when it comes to when we contrast it with the cost of healthcare today. One of the things that often goes untalked about is the social reproductive side of it, where you have all this labor and effort that goes in, quote unquote, behind closed doors that doesn't get recognized, doesn't get paid. Obviously, if you're, doing child care or care for the elderly, or, just taking care of your family, or, learning on your own time to get a better job, these are all forms of labor that just don't get recognized. So not only do mental health and, well, I guess generally healthcare costs get factored in based on, your wage labor and your medical coverage, but number three thing which it costs us probably the most is the time that we're putting into it. And it's this unpaid labor that really eats up the most part. For people who have to work multiple jobs, there is no time to put into your own health. In fact, that's, it's not just a one-way street either. It obviously cuts both ways in that case. So yeah, as far as the socioeconomic barriers go, this is very much a class issue. This is very much a political issue. We don't have the infrastructure, and right now, I think it was Emma Dowling just released a book last month called The Care Crisis, and it mostly focuses on England's care crisis, but it tackles it globally as well. Care in general is just getting less and less as far as an industry goes. You have people getting paid less and less to actually do the care, and we have a whole global population that's just getting older and unhealthier as we speak. And so considering that care is supposed to be kind of this invisible thing, something that's supposed to happen behind closed doors in private, we're losing. No one really knows the economic impact. We only know it through how we address it in some sort of secondary effect. We look at those care workers who are doing it during the day and working a night job and telling them, well, you just got to get a better job, or you got to get an education. You're doing unskilled labor, quote unquote, and that's unfortunately how healthcare is kind of viewed. So between that side of it and then this other side of, we have this almost caricature of how we view mental illness and suicide, and we kind of wrap it up more often than not in this kind of this homeless caricature, where it's this self-contained persona of, they're crazy because they're homeless because they're crazy, and there's no way out of it. And that's seemingly our best tolerance of mental illness today in society, and that's as close as we allow it to get, considering that we kind of explain away that person's poverty and their economic situation, the very material disparity of where they're at in their life, by the fact that they must have already been crazy. They must have just been born crazy. They got stuck in it, and obviously they can't work, so that's just their life. It keeps us feeling safe. It keeps us feeling content and secure about our future. And the unfortunate fact is that future is coming for us in the morning if we don't start tackling this as an actual political issue.
We often we put people in an othering box. That's not me, that's not my family, that's not my experience, and we can be very singularly viewed in our life experience, and yet this country has been built on the backs of hard laborers, of BIPOC people from the get-go, right? This is a country that was founded on this image that we can create our own, but we genocide an entire race of people and put them into places that are still recovering today, that still don't have the same advantages that really white America has. And we're a capitalistic society that does not share the wealth. The last several years, our policymakers have cut social welfare, have done so much pain and hurt to these communities that we're seeing this uprising in this pandemic. We're seeing social justice movements that are growing louder, that are frustrated that change hasn't happened, that they are not given the same opportunities that the rest of us, quote unquote, are given. And it's a real problem that if we were to prop people up and rebuild these systematic, oppressive institutions, that we may be a healthier people overall.
And to kind of add on to that, I mean, kind of a good parallel here, I think, exists with regard to sex trafficking. Like, people didn't get on board with sex trafficking as a growing problem until about like 10, 15 years ago. And to no one's surprise, it's only ever addressed as a problem of the global South. And so, as these people who are getting trafficked are people who need to do sex work or are victimized or vulnerable people. And so, I mean, what really kind of comes to the front should be this formula that should be very clear that, capitalism can't exist without sex trafficking, and sex trafficking wouldn't exist without capitalism. Of course, that's not to say that sex trafficking has only ever occurred in capitalist countries, but rather to traffic and commodify a human being requires a globalized market for that to move around so easily and to become an actual global issue. So if we continue to outsource these specific lower forms of labor and just view them as an issue of the global south, or as Amelia put it, as this othering, we will keep up with this view that these crimes are not of us, quote unquote, civilized people in the north. And the same goes for suicide. Until the general temptation stops being toward the view that this is something people here don't do, or it's from bad genes, or it's from hanging around lowly types, we'll continue to be shocked by it when it shows up at our doorstep. And what I'm really getting at here is that in order to take any sort of political step with it, any sort of form of communal action, this needs to be regarded in very specific politics. And I think there's really no shortage of communities that view this as being an issue of needing to decolonize these views. And that's really the specific type of politics that I think we need to approach with it is emancipatory politics. And there's plenty of organizations and movements, as Amelia hinted at, that are much aligned with this.
I see one of the bigger issues where I can kind of combine both of those. When trying to connect people to resources, they don't have transportation, or they don't have money to use public transportation, or they need childcare during that time, or they're going to have to switch shifts with somebody. I don't think that our systems are built to accommodate people the way that we would like them to, or the way that we think they are. Well, why don't you just go to the community mental health center? Because the community mental health center's entire budget got cut by 60%. So now they had to get rid of a bunch of counselors and caseworkers. And now there's a 3-month wait to get in. And then when they do have that appointment, they sure as heck better make it, but they still have to conquer all of those other barriers that they have. And then if they show up because they were able to, now those caseworkers and those counselors are so overworked and burnt out, they're not going to get the quality of care that they deserve. And it's all based on where they fall socioeconomically. And we're thinking, well, they should have done more. Well, they did what they did because that's what they could. If people could do more, I think that they would. But you get burnout, overworked people who are working cases and counseling people, and the outcomes aren't going to be as great. It becomes circular. And as a community, we should feel like this is something that's worthwhile. This is people deserve more dignity than that. People deserve more humanity than that. Just in general, people deserve more than what they're getting. I have friends who want to burn it all down and start over. Great. But we need a plan in between that. I just think that overall, as the people in the communities, as the people in the state, we can do more to advocate for those who can't advocate for themselves quite yet, because frankly, they just don't have the time or the energy to do so. So that's on us.
Thank you. I guess what I'd like to add to your point, in my career, I've been a CMH director. I've been a disability rights advocate for years. In 2014, when the state of Michigan cut the general fund to the CMHs by 65%, I was a director at the time, pretty upset about it. But I will say this, I've never been in a room with a bunch of primary care doctors who were talking about how to advocate so that their healthcare dollars for their patients with physical health issues, how do they preserve those dollars? I've never known them to have to deal with budget cuts. But as a CMH director, I had to sit in a room with other CMH directors and PIHP directors and talk about what do we do to hang on to what little bit of money that we actually had. And so to your point, the whole issue of the socioeconomic piece, who does public mental health serve? Either people with Medicaid, or if people have no insurance and they're funded through state general fund dollars. And unfortunately, since those have been cut, CMHs are allowed to create waiting lists, and people do commit suicide while they're waiting for services. And it's not the CMH's fault. Matter of fact, you now have CMH therapists that have these huge caseloads and can only see like a person maybe once a month sometimes as a result. So it does speak to where do we place our values? What do we value? Kristen, how are we doing on questions? Do we have any questions for the panelists that we should address now?
We have one, it's more really just, a comment. One was from Laura saying she worked with a CMH for a mental health court. It's hard to get appointments with therapists and psychiatrists, and there's a huge turnover. Therapists are constantly leaving for better jobs. One of our participants attempted suicide a few weeks ago. We could see him going downhill, but we couldn't get him to see a psychiatrist. He missed one appointment and couldn't get another.
And I think that's part of the problem is those that are in power are not seeing the day-to-day real struggles that individuals are going through. There's such a disconnect by design that, those that can sign the checks or cut the checks are removed from those that really need the help. And those that are on the front line, that are working for CMH, that are working, in private practices, are doing the best that they can with the resources that they have. And they're often, juggling a caseload of, 20 to 100, 150, depending on how the service is formatted. And we can only reasonably do so much as individuals. So collectively, as we've shared, coming together and using our voices and advocating for real change in our communities and from our legislatures, it does make an impact. And we do see change at the state and national levels when advocates and activists and peers and those with lived experience speak out and make for those changes.
We have Laura Mack would like to say something. Laura?
Yes, I was just going to mention COVID, and I've noticed, I'm the former district judge from the city of Wayne, 29th District Court, started a mental health court in 2013. People are not happy with telehealth services when it comes to therapy and psychiatrists. And that's really all there is right now. So it's harder to get people to go to appointments. I just think that the isolation is worse now. I think that way more people are at risk right now of suicide because of the COVID and the isolation. And there's less, there is telehealth, but I'm just wondering, I know that doctors like telehealth because it's easier to see a lot of people, quickly. I don't know that it's the best thing for people suffering from severe depression. And I just want your thoughts on that.
Yeah, epidemiology and mental health, historically, they go hand in hand, right? No, they don't. It's a whole new thing that we're having to go through. And it's not ideal because people crave connection and we're social creatures. We need that. Unfortunately, that's, the way to keep as many parties as possible healthy. I know that there's some therapists that just really like the idea of being able to have clients that are out of state who maybe used to live in state, and there might be hybrid programs eventually, but yeah, I can see that. I'm not a doctor, a medical doctor or any kind of doctor, but I think it's going to be left up to the people and the therapists. And if some, whatever makes it healthiest. It's not the greatest right now.
No.
We have a therapist on our board. She's an amazing human being, but yeah, she's seeing everybody through telehealth right now because that's what's safe for her family and for her clients. It's hard, but I don't know how to fix that yet. I'll let you know.
And there isn't a good answer for that in the midst of a pandemic. We have vaccines, but we know they're slowly rolling out, and not everybody is in line to sign themselves up for a number of reasons. And this is the current structure that we have. And I think it's interesting that we were able to pivot into kind of this technological accessible world, that there were the resources available to, bring, Wi-Fi into people's homes, bring laptops into people's homes to connect them to their workplaces, to their educational institutions. But as Katie said, it doesn't replace that one-to-one interaction. And talking to a voice on the screen, a picture on the screen is not the same as reading the body language and all that comes into that one-on-one interaction. And how to make that engaging is, I think, the challenge of the current environment. And if there are other clinicians and providers that are in attendance, please share how you are engaging with those that you interact with, or peer supports of how you're ensuring those connections are made, because there's not an easy answer with this, right? There isn't, a safe bet of this is who you can meet with and see you face to face, because it's not the same, and it's not going to be the same for a while, maybe ever. This probably changes how we receive and interact with our service providers, because there's many benefits, but there's also a lot of drawbacks to it. And, there's people in the camps of, I want to keep it this way, and others that can't wait to get back into services and really see their people, because as humans, we're social creatures. We need a people.
I do have another question. One is from Christine. How is parity working under the ACA, and is it across the country, or have only certain states adopted it?
I think I can address the parity issue, because last session 2020, Mental Health Association of Michigan was working on parity legislation. One of the issues that we have is that even though we have the Affordable Care Act, the federal government leaves it up to the states to enforce those provisions of the law. And that's where we have the issue, is encouraging the state of Michigan to actually enforce those provisions of the ACA. So at this point, we don't have, our legislation last year didn't get any traction, and we're looking at reintroducing it. But right now, we don't have solid enforcement of the parity law or those provisions of the Affordable Care Act right now in the state of Michigan, unfortunately.
How do you listen for signals that show someone is at risk for ending their life? It's actually a two-parter. And any ideas on how those skills can be published in the popular media?
Yeah.
So how do you listen for signals that show someone is at risk for ending their life?
I'm like this on all of this. So, and here's why. Because somebody can show every single warning sign and be within every single risk factor and be fine for the rest of their lives. They'll never consider dying. And somebody could show no risk and have no warning signs, and they could kill themselves. So it's not black and white. It's not like you've got a lump in your boob and now you should go see a doctor. So I don't want it to be very black and white, like this person is exhibiting A, B, and C, and they have these risk factors, so they're gonna try to kill themselves. I don't want anybody to do that. It's a fine line between like overreacting and underreacting. But warning signs and risk factors, I've shared them on the news a bunch of times and with a lot of media. But yeah, we probably could do a better job of sharing the listing overall. As far as what they are, we can pop a link into the chat, I'm sure. I know AAS has a list, the AFSP has a list, NAMI has a list, MHA probably has a list, and they're all located on websites.
I think it can also be a false narrative of how those warning signs are attributed to those that are at risk, or you believe that may be at risk. I think some of the factors to consider for an individual are the changes in their life. Are they struggling with a mental health concern? Are they talking or addressing that verbally or through their social media posts, if they're on on social media, if they're having a loss or the threat of a loss, whether it's a relationship, a job, and family situations, or struggling with substances. Those are some of the factors that really weigh into situations. But again, it's down to the individual and what it means for them and starting that conversation. I think Andy was speaking earlier about, predictors for suicide. And as much as we know very little that can reasonably predict suicide. There are some really smart people doing really great research and data research on our social media feeds to see if they can automate and really pull this information out. Those risk factors are one piece of a very large conversation. And more we are hearing about mental health and suicide and crisis that happens with individuals. Having those conversations is sometimes just calling up your local stations or calling up your radio or your public figures and putting this on the radar of, hey, could we talk about this, or could you do some research and bring in some panelists like you have before you. And we're just three voices in a large pool of those that are really invested and interested in this work and having these challenging, complex questions, because there are so many factors that really do play in to suicide, many of which we know and many that we still don't.
Mm-hmm. Like, I do encourage people, if somebody is around you and you hear them say, or they're posting on social media that they want to die or they feel like a burden, a lot of people like to label that as attention seeking, but generally if somebody is saying that, they probably need some form of attention.
Right.
They do. Nobody just like willy-nilly, I want to die. I want to kill myself. Nobody, ha ha ha. People don't actually put that up there as a joke. There's some truth to every joke. Take those things seriously. People are like, I didn't see this coming. And you look back through somebody's social media and they're like, I just want to die. Somebody kill me. Why am I still alive? Why did I get out of bed today? And you're like, yeah, it was a total shocker. Yep, absolutely. You just didn't take it seriously because you didn't see it as something serious to take. We think of somebody in crisis as somebody who's pacing up and down the halls, banging their head, sitting on the floor with their hands over their face like this. What we see in, the visuals associated with somebody who's in crisis. We don't think that it could be the person standing next to you laughing, or your friend at work who throws pickles at you. Like, it's not, we don't see it the same way, but it is everybody and it can be anybody.
What's the most important thing a person can do or say for loved ones who might have suicidal thoughts, especially during times of COVID, when you might not see or talk to others as often?
It touches on a similar thing that happened in 2018 after Bourdain and Kate Spade died by suicide. There was a moment where, all of a sudden on social media at its most prevalent, everyone was posting, anyone in care, like anyone in crisis, reach out. And then understandably, the backlash was, well, no, we're the ones suffering, you reach out to us. And of course, that causes this double-edged sort of anxiety of like, oh no, like we have to always be constantly checking in on these people that we're concerned about. And now the sole responsibility is on us. And then on the other side of it is, well, I feel awful all the time. Why do I have to put in the effort? Like, why do I constantly have to put in the effort only to be disappointed? Given the social alienation that we feel today during the pandemic, it's certainly not easy to figure out what that thing could be or what that looks like. But just know that it definitely doesn't come in the form of saying socially distance. It doesn't come in the form of saying who is and is not an essential worker. We're getting just pelted with all sorts of euphemisms that are very much related to one's self-worth and self-value, that are all based around essentially getting the economy back on its feet despite the pandemic, despite how we might be feeling at home. And to touch on the whole teleservice thing, like we're not in that room where that comfort's supposed to come from. You're not having that one-on-one conversation. You're talking to a computer, and yet the mental health care still costs the same. So anyone who was skeptical to begin with about psychiatric services, psychologist services, like it's only going to further it. So in order to address what would be best to be done or said when you can't, be with someone, you can't hug someone, I think personally, I think it kind of comes in the form of some sort of collective action. I think it comes in the form of not just saying I'm here, but building a community about it. Like if we have to be separate, if we have to be apart from one another, if we're all in disparate homes right now, how does that function? How do people protect their workers' rights? How do people ensure that they have job or food or water security? There are ways of still collectivizing and doing that collective action right now, and it's being done. It's just very difficult. So I would think, I know what would work for me is to begin building that community, and not just coming out and saying I'm here. If you want to talk, it's more, hey, what should we do about this? Like, what can we do? We got a lot of time on our hands right now. What is there to be done?
And that collective action, that community care, we're seeing even more individuals in communities. In Madison Heights, there was a great need for a food pantry that did not exist in the city. And a group of individuals took an idea and ran with it. And they've served over 11,000 meals to people within their community that needed help. Without question, there's no intake program or form to fill out. It's, my family's in need. I have 4 members of my family. Can I come pick it up at their own open pantry? And they've also been able to work with volunteers, it's all volunteer run, of finding those deliveries. So it's finding these creative pieces and like-minded individuals to create those communities, like Andy was just sharing, of taking action and getting involved, making the phone calls, texting individuals, getting on, the video chat apps that are now seemingly readily available if you have, the technology and the Wi-Fi available to connect with one another. I feel like I've talked to more people this year than I have ever in my lifetime. That might just be the weight of all of the technology in my life, but I feel more connected in some ways than I had in previous years, just by virtue of being a working adult with a family and all that comes with that. Showing up, contacting and following up with your neighbors, with your friends, with your family, starting conversations at a safe distance with individuals is part of building that community of care. A colleague, a friend, shared that the cultural aspects do play a significant factor. Part of what brought 6 Feet Over was that cultural piece. This culture that there was clear pain in the community, but nobody was addressing it, and nobody was showing up and rocking some fine ass hair and some great earrings and starting conversations that needed to be had. There was a lot of pain and there was a lot of hurt that was going on, and I would attribute 6 Feet Over, Suck at Suicide to changing the narrative, especially in the Metro Detroit area, in these non-mainstream communities of artists and musicians.
Yeah, I mean, it can be done from afar. So
it's not easy. Nobody used to talk to you.
So a great example of this is all of the families I've ever worked with, and we've worked with 33. Sorry, we had a new number. We were 33 families, and I never met any of them in person. I've met a few of them. I've met 3 since after their entire process, but I never met in person. I had never seen one of the family members that we worked with face to face until this past October. And it's because she lives in Northern Michigan and we're based out of Detroit. So everything that we ever did was either by phone or email, because Zoom only recently became a thing for us. I had a bond, and I still have a bond and a connection with every family that we've ever helped. I know I could tell you all of their stories about all of their children, about where they live, what resources are in their community. And it's because of email and phone calls. So it's not impossible to have that connection while not being right there with them. Woman that I spoke to, the family member that we helped, she's now trying to make her farmhouse into a sanctuary for loss survivors and a place for them to go. And she's told us that we are part of the inspiration, knowing that there were no resources around her directly, and feeling how she felt being able to talk to somebody who had gone through it. And she didn't really feel the SOS group support setting was appropriate for her, but she wanted someplace for people to come and sit on her front porch and drink a beer and swear and talk about whatever they were feeling. There's ways for us to make those community impacts, and there's ways for us to connect with other people without having to overburden any one system. That's one. Two, within my own friend community, we just text each other. So-and-so's having a really rough time. So I'll send soup to their house with a nice little message. I have cards, like little blank cards on the inside that on the outside it says, "I'm sorry, life sucks." Or I hear there was a pile of shit on your doorstep. Let me fix that for you. Like, you can do little things like that that will help people feel seen and connected. It doesn't have to be some grandiose, let me make a plan with you, but you can also do that too.
Part of that too is the conversations that we have with people. I think Jan earlier mentioned toxic positivity, and toxic positivity is harmful. Talking and having the range of emotions that we have as individuals and validating those experiences is so valuable. And we don't have to have an answer, and we don't have to take a positive spin on everything, because sometimes there's just not a positive spin. When life is awful, it's awful. And processing that in whatever healthier way. I mean, there's unhealthy ways, and that's a choice, and that's a way to cope. And sometimes just coping the best you can is what you can do in that moment, whether it's laying in bed for the day or a week. Finding some of those basics of just getting up, brushing your teeth, maybe brushing your hair, taking a shower, getting something to eat, and going back to bed is what you need to do. And that's okay. And letting people know that those are ways that they can cope. We don't teach how to deal with stress in school. We don't teach how to cope with traumatic events in our traditional institutions. Sometimes just getting through the day is the way to survive and the way to thrive, and just letting people know that it sucks. Sometimes being a person is really hard.
Thank you. I'm just really enjoying listening to the conversation. I think one of the thoughts I'd like to add about the whole concept of community support is that in other communities, indigenous cultures, you don't see quite the degree of separation between the members because of the way that they live their lives and the support, the community support and the family support that people have. Also, there's a tendency to not pathologize people who are different. There's actually a great movie called Crazy Wisdom that talks about people with mental illness actually being medicine men and women and shaman and other cultures. So, but the point is that we are very separate from one another. And sometimes what people really need more than they even need to see a therapist or to be given a bunch of psychiatric medication is to be taken in by other people and just remove some of the stress. So if it means sending them a message or providing soup or watching their kids so they can get a break, or family, taking care of things for someone just so that they can get some respite. Because really, if you go into a psych unit, in a way, it's a strange kind of respite. I mean, it's really a way of protecting you from self or others. But there are ways that we can do this, similar to what you were talking about, Amelia, in Madison Heights when they were feeding people.
Yeah. I had a friend who had made an attempt, and she had been depressed for years, and it really all weighed down on her one night, and she made her attempt, contacted a number of people, and we responded, and we were able to clean up her home when she was able to go get the treatment that she was willingly accepting. And we cleaned up the home that had just fallen apart and was not livable for her. She didn't want to live that way, but didn't know how to dig herself out of that. So that was a very just getting your hands dirty and showing up for your people was just one small example of doing what you can do to help somebody. And making sure that her dogs were taken care of was the other part. That was an important part. But yeah, those sometimes it's just those small pieces that can mean so much.
If you could pass one law or piece of legislation or bill that could help mental health, what would it be?
I would personally like for anybody who is going into the mental health field and will be treating clients to have mandatory training in suicide prevention, and suicidality. Mandatory, more than one unit, which is pretty much what it is right now. It needs to be an entire class. They need it.
Thank you. Andy?
I mean, there's so many things I wish happen. Probably the first thing that comes to mind is some sort of I guess public task force or some response unit that could respond to wellness checks or mental health calls, so we do not have to rely on the police to respond. At least someone who's unarmed going into these. Wellness checks are one thing, but they just heighten the anxiety of those situations, especially when you have someone walking in with a gun. Then the other side of it, when you do have someone having certain episodic tendencies, definitely don't want to bring police in who are drawing their firearms on someone when they're out on the front lawn. I mean, ideally, it would be something like that. Knowing the neoliberal nature of the system, it obviously would last 4 years and it would get cut. So I don't have a lot of faith in that public system of it. But yeah, I guess it would stem around that
Crisis response team, basically.
Mm-hmm.
It's similar currently. So the restructuring of the current mental health system from the top down, from how clinicians are trained, what they are trained, support of peer supports that are in the community, that are embedded into all service aspects, those with lived experience, to better inform the care providers and how people get access to care, supporting the services from crisis intervention to traditional mental health space to crisis respite care, retreats and follow-up services that allow people to get back on their feet, whatever that may look like, in their communities and in their homes. We don't get sick in silos. We get sick in our homes and in our communities, and we need to look at every aspect and do a better job overall.
Because Andy will write a complete dissertation on this. Yeah, too. So.
If I must.
Oh, CC me, bro.
Well, before we wrap up, I'm just wondering if Kate or Amelia or Andy have any final thoughts before we say goodnight to everybody.
There is no one-stop shop to suicide prevention, to suicide intervention and postvention. A very kind friend reminded me the cultural aspect plays such an important role, and we don't have a good hold on what that means from our singular perspectives, and being responsive to that and acknowledging that different communities need different services, and that's okay. We don't have to have this very black and white, this is what it looks like. It's going to be multifaceted, and it needs to be.
I just enjoy that people actually seem to give a crap now. And when I started doing stuff, I would mention suicide and people would back away slowly, and then it would fall into like a slow jog away from me. So understanding that there's communities of people out there that aren't just clinicians and aren't just working in the field, that are interested in learning more and being better citizens and peers and communities, that's just rad. And to me, that shows a great change. And so far in our society, we can do a hell of a lot better, but I'm proud of you all for being here. Thank you.
Thank you. Andy?
I guess to wrap up, if we keep talking about suicide as an individual problem, if we keep ignoring the social, if we keep repressing the class content of suicide, we will keep defaulting back to this neoliberal view that we all have to be entrepreneurs because we as individuals are the epicenter of all success and all failure. So anything like suicide or mental illness can only ever be viewed as a personal failure. Like we didn't do enough to prevent it. We didn't do enough to intervene. If we keep up with this individual approach, it will come for us in the morning. And if what Chico Mendes said about environmentalism is true, which is ecology without class struggle is just gardening, then psychology without class struggle is just relaxing.
Well, thank you, Andy. Thank you, Kate. Thank you, Amelia. Thank you, everybody, for attending today and for participating and joining us in this discussion. MHAM is going to be having webinars on a variety of mental health topics every other month. It sounds like this is a subject that we will be revisiting at some point down the road this year. So thank you all for coming today. And again, thank you to our panelists. And thank you to Kristen for always doing such a great job as the moderator. I hope you all have a really good evening. Thank you again for your time and have a great evening.